Hello and welcome. This is Chris Roberts with IATRIC Systems, and I'll be your moderator today. If you should need any technical assistance during the webinar, just refer to the information located in the questions section of the control panel, and my name and contact information are there for you. We encourage you to participate in today's webinar by entering any questions or comments in the questions section, and you may enter your questions at any time during the webinar. For quality purposes, this webinar will be recorded. And then after the webinar, you'll have the opportunity to fill out a short survey to tell us how we did. And this survey will appear when you leave the webinar. And for your time, your name will be entered into a drawing to win a $100 Amazon.com gift card. All those drawings are held at the end of each month. We really appreciate you joining us for today's presentation, What's Up with CMS Quality Rules. Our speakers today are Kay Jackson and Cindy Paul. Kay is in charge of education and advisory manager for IATRIC Systems. She's held various product management positions since joining IATRIC Systems in 2006, including meaningful use and revenue cycle improvement. She brings over 35 years of experience in the healthcare industry. And then Cindy, a registered nurse with over 20 years experience in clinical nursing and public health education, is a consultant in our professional services division at IATRIC Systems. She's experienced in hospital compliance and quality improvement, including meaningful use and audit readiness. Cindy's primary role at IATRIC Systems is clinical consulting and project management for CMS quality initiatives. And I'm going to turn it over to Kay to get us started.
Thank you, Chris, and hi, everybody. You know, Cindy and I did this presentation at a hospital convention in May, and we thought this was a great chance to really share more information with more people. We had some great comments. People came up and really liked the presentation. And I'm going to bring the revenue perspective or the purpose for each of these programs we're going to talk about, and Cindy's going to bring the clinical aspect. So we thank you for coming. We're going to upload a copy of the slides right now so you'll be able to get them. But if there's team members that weren't able to attend, we will have the playback link we can share with you. And feel free to email Cindy or myself if you have any questions. And don't forget to put questions in the chat. So let's get started. Why are quality scores so important? Well, it's pretty intuitive. Everybody pretty much understands quality is how you base what you do, basically. I'm going to date myself, but I can remember when I first started in healthcare in the 70s, a hospital bill was typed, yes, with a typewriter, had two sides, a front and a back, total charges, no departments. I mean, it's just the department totals, grand total. That was it. That's how we billed. Then in the 80s, the UBs came along, and that started the process to give more information, break down by departments. Then the electronic claims came in the late 80s, then electronic payment. So why I brought that history up is we've done a lot of the heavy lifting to get to where we're at with the submission of electronic claims to be processed. Now we need to go to that next step with quality, and how can we improve the quality in the U.S. So that's really what we wanted to focus on today. So is quality just for CMS, just Medicare patients, or is this something that we're going to see kind of move to other payers? And the answer is yes. You know, CMS first started the Hospital Compare website in 2005. So that was kind of their first step to saying, hey, quality is important to us. They just updated it last month, in fact, on July the 27th. So you might take a look at what's changed. What's happening, though, is the commercial payers are saying, hey, look what they're doing. Maybe that's something we need to start doing. And I'm going to share some information with you of what they are doing. So why did CMS want to compare quality? Well, it's two reasons, I think. First of all, the patients that they represent. And then second of all is how can they reduce costs? They just released the star rating. I don't know if you've seen all the talk about that. There are 12 HCAHPS scores that are included. And they updated, like I mentioned, they updated the website. It really is a way that helps people understand what's going on at the hospital about the quality. You can compare facilities. You can do a side-by-side comparison. There's important questions, though, that are asked about quality. And what surprised me about the star rating, which has quality basis as well, there were 3,617 hospitals, and how many do you think got a 5-star rating? Only 102. The lowest rating had 129 hospitals, and that, to me, that in this day and time, that is just appalling. There are actually in the U.S. over 1,400 100 star, 5-star hotels. So we have a lot more 5-star hotels than we do quality hospitals based on the current process of how they're doing that. And many of you that maybe have heard me speak on the revenue cycle side know I started my career in the 70s on the medical claims paying side, the dark side as it's called. And back then, a hospital bill, we paid the percent, usually 80%, the patient paid 20%. But what started happening, and I saw it in my career, was the commercial payers started looking at different ways to cut costs. They came up with, the per diems and some other things that could really reduce what they had to pay out of pocket. So this is another way that they're looking at and saying, CMS is doing all this quality, maybe we need to do it. And when it would impact you, of course, would be your contract renewal. So what is value-based care? To me, it's a lot of pieces. It's a puzzle that you almost have to put together because there's so many different programs. But CMS gave some statistics in one of their webcasts in June, and if you're not attending those CMS webcasts, you're missing a huge opportunity. The federal government says they're 11 months ahead of plan for their schedule for the 30% of Medicare payments to be alternative methods. So instead of being behind like they normally are, they're ahead. They've just announced they're going to start testing value-based on Part B drugs, so that's another thing we'll have to look for. And they're also going to start bundling payments to hospitals that perform hip and knee surgery. And so I'm a baby boomer, all of us that are coming of Medicare age, they're making these changes that can impact how the hospital's reimbursed. So I say a big question to me is, are we ready for these changes? Are we ready for historical change in healthcare? And I don't know if you ever read Michael Levitt. I really think he's a trusted healthcare consultant, and he wrote an article, and I've used this analogy before, but he said, ignore the perils or the signals of value-based at your own cost. If you don't start doing it now, you're going to pay later. And he gave the analogy, I think it's awesome, like Cinderella at the ball. Go back into our childhood with Cinderella, and we know that the coach was going to turn into a pumpkin at 12 o'clock. She didn't prepare ahead of time. She waited till the strike of midnight, and we all know what happened. And he said that's how it's going to happen with value-based. Fee-for-service is going away, and we have to be careful what our pumpkin time is. So like it or not, we've got to get ready for that. We've got to align ourselves to what's going on and really set up our models to match that. So CMS, when they set up these value-based, like I said, commercial payers are looking at it, and in fact, what CMS has said is you've got to have the right technology and the data methodology to succeed. They're looking for you to build relationships with providers, and that has to change dramatically from how we used to do it. And they said that value-based, when you have failures, look at that as an opportunity for learning. I'm not trying to scare you, but prepare you. We've got to change how we're doing things in hospitals. And I think the performance improvement staff, this is your time to shine. Revenue has dwindled over the years, and we see hospital layoffs. Would you believe 12 hospitals have already closed this year, totally closed? Less revenue, and so it's only going to get worse if we don't prepare because it's going to hit our bottom line. And this is just a graph about the incentives versus penalties. And I went to an HFA meeting recently, and the CFO presented how they really talked to their physicians, shared where the hospital was losing money. And it took about 18 months, but they actually became partners, and that's what we've got to have. So Cindy, why don't you add some more about value-based for me?
Sure. So in 2016, this is kind of the model that was followed for value-based purchasing. And listed here are a few things that were new for 2016, namely the immunization for influenza, a part of the clinical process care domain, also CAUTI and surgical site infections, specifically for colon surgery and abdominal hysterectomies. So moving on to 2018, you'll see that there are lots of changes. So CMS decided that rather than there being several different pieces of the pie, they wanted to just kind of divide it out equally, where every domain is weighted by 25%. Now, something that I wanted to point out about this is the patient and caregiver centered patient experience, that 25% weight. So I learned something this week that I thought was really interesting. So as Kay was speaking of, we have so many 5-star hotels, I'm wondering if part of our patient experience and our patient-centered care is going to be transitioning even more, where we're actually starting to deliver service very similar in alignment with 5-star hotels. So just as an example with that, I was speaking with a previous coworker, and she works in a suburban area outside of one of the major U.S. metroplexes. And this week they're currently in the process of moving patients into a brand new tower that they've spent millions of dollars building over the last couple years. When she went to describe the new tower and the amenities, I was completely blown away. And it really was like it's in a 5-star hotel. So she went on to mention that the rooms are, twice the size as what they were before, and call bells are on kind of a synced system where if the call bell isn't answered within 30 seconds, then it goes on to, kind of the next higher chain, ultimately winding up on the charge nurse or the CNO's cell phone if that call bell is never answered. Also, something I found really interesting is that there are scanners in every single room. So anytime a staff member enters that room, then it automatically produces like an audit trail. So patients are going to know exactly who's coming in their room. They're going to know that staff member's name. And we're looking at more and more patient-centered care and patient quality. If you thought that patient surveys were difficult in the past, they're only going to become even more of an issue. And the goal really is to involve our patients in their care and be able to meet those high needs and high requests that our patients come with at this time.
Well, what was removed from value-based? You can see we added a couple of items that were removed. And what happens is CMS, they max out, or as CMS calls them, topped out. They're going to replace them, and they're going to ask you to monitor different things as they move these topped out off. And what I suggest is keep your workflow for the ones that are removed. It's kind of like the analogy I look at is when CMS changed, under meaningful use, there was a portal requirement, and they lowered it for 2015 to a single patient. Well, what happened is workflow shifted. People stopped asking patients about getting on their portals, and it took a back seat. So don't have that happen with any of these that are removed. Make sure that your workflow continues. And I put prepare for change. So these are some of the changes, of course, that are coming. I mentioned attending the CMS webcast. If you don't know how to get on their mailing list, let us know. We'll tell you how. They have a lot of amazing sessions, and they actually have hired a third-party company to help them oversee education for value-based. So they're taking it very seriously. There's lots of good newsletters. There's a blog on QNet that's amazing. And, I'm asked all the time, okay, we don't really think anything's going to happen. There's going to be this election this year. Things will probably change. And I tell them, regardless of who's president, I think this is going to continue. This is where we have to go. So I've kind of been talking about quality and commercial payers, so kind of hold on to your seats because this is what's happening. CMS and the American Health Plan, which oversees a lot of the commercial payers, are working together for a change. They're going to move to more of a change some of the complexity of reporting and merge them together. The three largest payers are currently involved, and that's United, Aetna, and Anthem, and they cover about 1/3 of the population. So they're saying, hey, this is working for CMS. We're going to do it too. So just in the very near future, you're going to see more companies come and say, you have to now provide us with quality statistics. We only want our patients to go to quality. So it's just a quality hospital, so it's not going to be just for CMS. So keep that in mind. A few examples of the regulations now in place. We thought we'd cover a few. We wish we could do all of them, but I remember back to the 90s when observation first came out and we had to educate our doctors. The same thing now. We need to make sure all of our staff know about all of these and how they impact the revenue. So Cindy, I'll let you go ahead.
Yeah, why should we track the measures in real time? So just thinking about it a bit, as we're talking about our value-based purchasing and really focusing on patient-centered care, the main thing about tracking real time is that it allows clinicians the opportunity to make changes right then and there, whether that be in a patient's condition, whether that be in their satisfaction. Oftentimes, if you have a patient complaint, then there's opportunity that we can go make amends to that patient, or make efforts to try to correct the issue to overall change the course or their perception of their stay. The other thing that I really want to focus on is tracking real time enables us to avoid deteriorating situations in a patient's health care. Whether they have a condition that, whether it be sepsis or another condition that's really making some downhill changes quickly, if we're tracking that real time, then we can make changes to change the course and then improve that situation. So ultimately, by doing this, we're going to improve our reimbursements, and then also all of these scores are going to your hospital compare. So it's very important to make sure that you're staying on track of this real time, because it may not be reported. For instance, your ECQMs aren't going to be reported for hospital compare this year, but that will be coming down in future years. So just want to keep all those things in mind.
Thanks, Cindy. Chris, I thought, is there any questions yet? We don't want to get too far down the road if there's any questions that are out there in the chat.
There actually are just a couple of quick things. One is, if you have a question, don't forget to put that into your questions pane. And then one of the questions we had was, are there slides available for download? And those have been uploaded into the handout section of the webinar, and those also will be sent out later. So just wanted you to know that. But Kay, we do have a question. What did you mean when you indicated that other payers are going to track quality?
Oh, that's a great question. Like I mentioned, they are working with CMS, and what that means is they're going to mimic what CMS has found successful. When I was on the dark side, we did this all the time. We looked for ways to reduce our costs. That's what insurance companies do. So they're going to see the success and quality programs that CMS has started, and they're going to mimic those or include those. So start watching your contract renewals. You might start seeing a requirement in those for reporting. And what they're also working on, and Cindy's going to talk a lot about this later about the QRDA, they're working on having those payers adopt that same methodology, the QRDA Category 1 reporting, so that everybody that wants quality will use the same standard for reporting, which would be awesome. Well, let's get started then. We're going to start on readmissions, and Cindy and I are going to review some of these important CMS requirements, like I said, and I'm going to give the regulation and purpose, and Cindy's going to share her ideas as a nurse for each one of those. So readmission, the history of that, CMS started in 2012 as part of the Affordable Care Act, where we got a lot of new things. And in 2014, there were actually $935 million in penalties. And we keep getting all of these penalties assessed to us. Our revenue is going to go down, and that means there's going to be things that are going to change at hospitals. And so this program, which is called the Readmission Reduction Act, really tracks the rates of readmission for certain diagnoses like AMI, heart failure, pneumonia, acute COPD, THA, and TKA. And remember, this reporting is based on your claims. So it's nothing that you track or report. So if you're not having some mechanism in place to really know what your readmission rate is, you can't fix it. And so what it does, it looks for patients that are readmitted to any acute care facility within 30 days. And if they are readmitted, then somebody's going to get a penalty. It's going to be based on a lot of factors, and this is how CMS determines that. They take that excessive readmission ratio using claims-based data, and that's, of course, ICD-10. Currently, that's what they're doing. Again, it's not information that you report to CMS, but if their predicted readmission rate exceeds what yours is, then there's a penalty. So again, knowing what your readmission rate is and knowing how to change it is very valuable. So Cindy, can you share some of what you think are ways that we could really change our readmission?
Absolutely. So I've been following this a lot in the last couple of years. And some latest research that has come out says that 1 in 4 readmissions are potentially preventable. Now, there's been even more recent documentation that's showing that that rate may be even higher, because the current data is showing that readmission rates are actually increasing. So as clinicians, are we failing our patients? Some of the things that I've been looking at are, number one, are we discharging our patients too soon? We all know that we have to follow certain criteria that, you know, the patients have to fit into that criteria specifically, and if they don't meet that criteria, then we have to start looking at discharging them. Well, maybe we need to start looking at some different processes to change that, just so that we're making sure that the patients aren't really going home too soon. Secondly, part of our patient satisfaction and patient-focused care is empowering them in their own care, providing them with the resources and the tools that they need to really start taking over their care and providing that education in a different way than what we've done in the past. Also, do we lack the continuity of care after discharge? Making sure that we establish those safeguards to make sure that patients, all of their needs are covered at home and beyond. That's super important. And we can't just always assume that they have their support systems in place. So we have to go above and beyond to make sure that they do have those support systems in place. Lastly, just the inconsistent communication between providers, whether that be between internal hospital staff or that be between a hospitalist and a primary care provider. The inconsistency in communication can oftentimes lead to a need for a patient to be readmitted. So one thing I want to consider here is it's about the patient, it's not all about the penalties. So whenever we look at this, yes, we're looking at our penalties and the financial repercussions that can come, but we also have to really consider the aspects about the patient. These patients oftentimes are losing their support systems that they have in place if they're readmitted. For instance, if a patient has to go to rehab or to a SNF bed and then they're readmitted for some reason, oftentimes it's hard for that patient to return to the same facility. And with discharge planning, all the folks involved with that, that can create challenges. We also have to consider the impact that patients have emotionally and financially. The readmission can, impact families as a whole in all of these aspects. And looking at, we all know that there are risks whenever you go into the hospital. So we're, potentially increasing the risk for adverse events. Potentially patients can become sick just, based on human error or, nosocomial infections, that type of thing. And that can also increase the patient's length of stay. So once the patient is crossing the hospital threshold, it's putting that patient potentially at risk for other adverse events. So what can we do to stop readmissions? First of all, it really starts at the front door. By using analytics in your ED, you can start tracking those high-risk patients and start involving care team members, care coordination within the ED to start establishing those safeguards and those systems in place to help the patient from the time they're admitted to the time they're discharged and continue that care continuum past the point where, they go home, they're making sure that their follow-up is in place, all of their needs are taken care of upon discharge. So really get the wheels turning as soon as that patient comes in the ED. You can use some type of analytics tracker or your EMR tracker to start flagging those high-risk patients. Get together your teams with your admission RNs, your case managers, home health, and also community involvement. All of these things are very important whenever you start looking at your family and community support involved. And lastly, really look at getting the primary care physician involved from the time the patient's in the ED. Though the hospitalist may be taking care of that patient during the stay, It's good for their primary care physician to be aware of, okay, we've got this patient coming back. You know, what safeguards do we need to put in place to prevent a readmission down the road? And something that I really noticed that was interesting in doing some of my research, and then also, you know, just talking to community partners, is it's really important to start getting skilled nursing facilities or rehab facilities on board. Also, you can use your EMS outreach programs where, you know, ambulance services or EMS folks actually go out and they do home visits or outreach with folks that they've actually gone out for a call. And also a really kind of creative way is involve your nursing school students. They can also do practicums or some type of thing to start reaching patients within the home as, you know, part of their clinical practicum. And that can also be an effort to help these patients reduce their risk for readmission. So those are just some ideas that we can actually go about stopping or, you know, decreasing the rates.
Yeah, and you know what I've always said is start, like you said, in the ED. And one of our customers actually created their own little tracking tool. They were watching for patients that were Medicare patients with those diagnosis codes coming back in the ER and alerting the doctor right then that, hey, this patient just left the hospital 2 weeks ago, you know, for a diagnosis of COPD. What are they coming back in for now? Learn from it, but also help that patient make the best choice in care. So the next one is sepsis, and I get emotional when I talk about sepsis because it really touched my family in a personal way, and I know it may have affected some of your families or other celebrities. There's a whole list of celebrities on the internet that died from sepsis. And the doctor told me if they had caught the sepsis sooner, my loved one would not have died. And there's a study, and I just wanted to give you these statistics so you can kind of pinpoint how important sepsis is and why CMS has added it. They revealed that in the last 2 years that the cost for treating sepsis has increased by $3.4 billion in 2 years. And it accounts for nearly $24 billion in annual cost, making it, you know, the most expensive condition to treat in the whole U.S. And it kills 258 people a year. And if you do the math, that's one patient or person every 2 minutes that dies from sepsis. So it's a huge impact. It's a financial impact. They found that the average cost for sepsis hospitalization was $18,000, way above the normal cost for care. So it's very high on the list with CMS. It's something that they've added. You know, they delayed it for a few years, but then they added it. So I'm going to let Cindy talk about the clinical aspect.
So sepsis really is a race against time. From the time that patient enters your ED, that clock starts counting right then and there. The best way to get on top of sepsis is to identify it quickly and initiate protocols with the sepsis bundles. And research has shown that any kind of delayed recognition truly impacts organ failure, and delayed treatment results in that high mortality rate that Kay is talking about. So the key here is making sure that we have early identification and initiation of treatment. And really a real key thing also is to be educating our folks in the EMS so that diagnosis and treatment can really start taking place once they're in the field. So another creative way that you can use different ways to identify your sepsis high-risk patients is to use analytics. And I put this kind of exhausted physician sitting at a computer graphic. You know, we've all been there. We've all been sitting at the computer looking at, you know, the EMR, going through all of the different pop-ups. So my question is are EMR pop-up alerts helping? Who's paying attention to them? Or are you getting, you know, somewhat of the pop-up exhaustion or pop-up fatigue? So my suggestion here is to use a different way to put pop-ups into action. So you can either change the way that your pop-ups work or do something to screen or, you know, signify that you've got a high-risk patient here. And this can be done within your EMR vendor or an analytics tool that you potentially use. So any resources that you have that are going to signal these really high-risk patients that are having deteriorating symptoms, then you can get on that really quickly with the early identification. Another thing is to establish a sepsis response team. So much like there's a rapid response team, it's really beneficial if you activate a sepsis team who can really be on guard for those high-risk patients and helping to identify them quickly. So talking about analytic solutions versus an EMR, we have found that analytics tools really are much quicker to assess changing trends in a patient's symptomology. Also, you can be able to make real-time decisions for treatment right then and there. Oftentimes, whenever we're analyzing data from our EMR, it's not real-time, and you're just looking at what your statistics were for, the week or the month or quarter prior. So using some type of analytics tool is very beneficial because you can look at that data real-time. And using this helps to avoid the pop-up fatigue.
Okay, now we're going to go on to the inpatient quality reporting, and it's probably the program that changed the most this year. We've always, for many years, had starting in 2003, had these inpatient quality reporting. The staff that does that are amazing. They take that chart abstraction information, they know where to look for the data, they know the rules, they've got all that in their mind. These are key staff to work with when you're trying to move that manual process to an electronic capture process. And we all found that getting ready for 2016 eCQM. So chart abstraction this year was 8 chart abstractions, but you also had to add the 4 eCQMs, and that's from 3rd or 4th quarter of 2016. So moving from a manual process to a electronic is huge, and data has to be there. The IQR was part of the Medicare Prescription Drug Act, and it does impact your market basket if you don't participate. And market basket is a measure of inflation of cost of goods and services used by a lot of the hospitals in treating Medicare patients. So it's very important that you understand what's required this year and you do that reporting. And Cindy has become an expert in this eCQM process. So Cindy, why don't you share a little bit about where we're going and how they can, make IQR work?
Sure. So one thing that I've noticed, you'll see that my first top item here is quality departments aligning with other teams, aligning with their clinicians, with IT teams. And something that I've noticed in working with clients in the last several months is that's happening, and I'm so excited to say that. A few years ago, back when we all started in the meaningful use journey, we found that there were silos of teams, and getting everyone all on the same page was often difficult. So just to emphasize, it's very important to have everyone on the same page, making sure that your clinical and your quality folks are working together, and then your IT people are all on the same page to say, yes, we can build that out. Yes, we can make that follow the best practice to create that QRDA. So I'm really, really excited to see that hospital cultures are coming together and there no longer are those silos. Also, I want to another thing to emphasize, this is another way that data analytics is really important in just making sure that your IQR is working for all of your data reporting programs.
Okay, thanks. And now we're going to move on to CQMs. And I feel like I was at the beginning of CQMs back in 2010 when meaningful use first started. And that used to be an objective under meaningful use, and they separated it and made it a standalone. Well, I think this is the first step where CMS is merging 2 quality reporting programs. And as I mentioned, the IQR and CQMs are kind of are merging this year. And by doing those 4 eCQMs, it covers you for meaningful use reporting as well. So instead of doing 16 manually, you can do these 4 that are mandated under the IQR. And Cindy's going to share a lot today about the hot topic that you've probably all heard. I've been to so many webcasts about it. It's that QRDA Category 1 reporting that I mentioned, the standard. And she's really going to focus on what you need to think about. But I want you to keep in mind that this is not just going to probably be a CMS thing. It's probably going to be a reporting standard that you're going to see across the industry.
So I don't know about you all, but these days for me, I'm living, breathing, eating eCQMs and QRDA1. So this may not just be completely Greek to you at this point, but I know that several months ago, this, the concept of eCQMs truly was. So I just want to talk a little bit about, coming from a nursing background. I remember starting my nursing career that there were abbreviations and acronyms for everything. And it seemed like that when I went into nursing, I truly entered a new world with a whole new language or lingo. So just as an example, I started working in the ED as a trauma nurse, and I will never forget all of the different jokes and songs that we would use to help remember protocols like MONA. So, here I have morphine, 4 milligrams, IV push, oxygen, 10 liters, nitroglycerin, ASA, 18 grams LR bolus, transfer to cardiac cath lab, stat, all of those different acronyms. I know as a brand new ED nurse, that was all completely foreign. And so it almost seems like that CMS had to sort of get on the same bandwagon with healthcare in all of the acronyms that they're producing these days with quality reporting and meaningful use. Everything has some sort of a Greek acronym, it seems. So let's just break it down a little bit in, eCQM is Electronic Clinical Quality Measure. The QRDA1, the abbreviation actually stands for Quality Reporting Data Architecture, and that's Category 1. That is the new focus for 2016. Before it was Quality 3. So if you see Cat 1 or Category 1, that explains that. I'm sure you're also familiar at this point with the PSVA, or the Pre-Submission Validation Application. That tool is actually part of QualityNet, and it's the tool that is used for testing and validation of your QRDA test data. All of that process is done to make sure that you're ready to go with your production data. So moving on, we can just discuss all of these in a little greater detail. The main thing I really want to point out is producing the QRDA1 file is not always easy. In fact, I work with many hospitals, and there are so many challenges among every step of the way. So the first thing that really is important is to make sure that you're following your vendor's best practice, making sure that you're documenting according to the most current workflow and value sets with the 2015 specifications. It's also important to make sure that you have your IMO or your nomenclature up to date. Many hospitals are looking at the IMO 2.0 platform, and there are lots of benefits to that. So if you haven't checked that out, I would encourage you to look at their new platform and consider that for your hospital. Another difficulty that many hospitals are finding in actually creating their QRDA1 format for their QRDA1 files. So there are many processes, and every vendor has a different best practice. So I would always refer you to follow that vendor's most recent best practice. And I'll just let you know that we work with several different vendors, and they are continually updating their best practice. One vendor that I work with actually was making updates last week. So just always refer to their website to try to obtain the most current changes that they're coming up with. And lastly, the last kind of step in producing your QRDA1 file is going through that testing and validation step. So is it really that easy? There are several different tools that are used to create the QRDA files. I know that many of you on the line are Meditech customers, and their format is the ARA Report Manager. I'll just let you know that in using this tool, it takes several different dedicated staff working, many weeks to go through the process of creating new workflows, creating the mapping, the nomenclature mapping, updating all of that in order to create the QRDA1 file. And that's done in the R Report Manager tool. Now, other vendors, other EMR vendors have different ways of creating their QRDA, and other quality vendors are also, looking at specific ways. Most of them are focusing on some type of SQL or report writing in order to create those files. So just keep in mind that this can take several weeks. New documentation queries or new data capture may be required in order to follow the best practice. You'll also have to make sure that your IMO or nomenclature mapping is up to date. And it's important to make sure that you're creating those QRDA files and getting everything ready to go to start testing and validating with the PSVA tool. So all of this has to be done at this point. We're looking at Q4, so October 1st. There's a lot to get done in a short timeline. So what's the process once you have your QRDA file created? What's next? So I've talked a little bit about the PSVA, or the pre-submission validation application. This is a tool that is part of QualityNet, part of the secure portal. First of all, there will need to be an account registered for with QualityNet. This is typically someone in your quality department or someone who's been submitting those core measures for the past years. You'll also have to have an assigned EHR data upload role, and this person will also need to actually install the PSVA to that user's desktop. So simply having the QualityNet account is not all that's required. There's an additional step to actually have the PSVA capability. So starting to test those QRDA1 files and validate against the CMS requirements, there's two separate steps to that. So the first step is the validation step. Once the PSVA has cleared all of those warnings and error messages, then you can actually submit test data to CMS through the testing tab on PSVA. So each of these steps requires corrections for working through the warnings and the errors, and this all has to be completed before you can start submitting production files. So I guess just another thing that I want to point out is that this process gets you to production to start your reporting period. In no way does this help meet your requirement for your eCQM reporting. So this is all just the back build and the testing and validation step. So moving ahead, in looking at 2017, CMS just released some information about what CQMs are retired. So thankfully, the original list that they came up with has stayed the same, and we've listed those out on this slide. I want to just point out that just this last week, they did release kind of a pre-final rule. In that release, they said that for 2017, we'll be moving forward with 8 CQMs as opposed to 15. And the originally proposed 15, you can make your selection from that. So there was other information that I read that really helped to kind of steer folks in certain directions. So I know that the newborn measures, the newborn hearing screen, elective delivery, those are measures that CMS is indicating, hospitals may not have used in the past, but they're certainly encouraging that you start establishing your workflows and your build to work in that direction. So as far as the PSVA, to start submitting your QRDA1 files, PSVA is open at this time. I have been working with several clients through the process of submitting test data and working through those errors and warnings. Now, I would just have to say that this isn't only a challenge for hospitals, it's been a challenge for vendors and CMS and PSVA alike. So, you know, it's very beneficial to be reading blogs or QualityNet, looking at, you know, different boards and helping to get all the information you can to work through those errors.
Okay. You know what, Chris, I think I'll see if there's any questions before we go on to the last part of this presentation. Are there any questions?
There are. There are a couple. One is, how do you get the PSVA installed to a user desktop?
There are instructions on the QualityNet website that can walk you through the process. I also have kind of a step-by-step process. If you'd like to reach out to me, I'd be more than happy to share that with you.
Great.
Thanks,
and
Cindy.
then why is the government moving to value-based?
Well, I'll just give my 2 cents. They had no choice. We had reached the time in our healthcare history where the cost for healthcare, you know, was just too much. We had to change, and I wish we had changed to the quality sooner. So this was how they came up. Will it work? Will they have to alter it? Probably. Most programs get altered. Look at how many times meaningful use has gotten altered. So I think that that's why they had to choose some way of really showing the value of quality, because we'd gotten away from that in a way. I'm going to go ahead, due to time, and talk just a little bit about a couple of others. The HCAHPS scores, we mentioned how important they're going to be going forward with the STAR program. It actually started in 2002, and in 2005 it was endorsed by the National Quality. Everybody knows about NQF, and it was implemented in October of 2006, so it's almost 10 years old. The HCAHPS survey, in a way, you know, you hire a third party, they send out to all your discharged patients or a subset of your discharged patients asking 27 questions about their hospital stay. So do only your patients that have great care respond to the survey? No, you really need to encourage your patients, if they receive the survey, to submit, because what we found a lot of times was only the patients that were unhappy would answer the survey. And that won't be a really good indication. There's a real good fact sheet that CMS has come up with about HCAHPS, so if you'd like to have that, you know, let Cindy and I know. A lot of the things we've mentioned today, we're happy to share with you. So Cindy, give me the clinical view. I kind of talked about the real reason we have it, but what's a clinical view of HCAHPS?
Like I mentioned a little bit before, hospitals are looking more at patient-centered care, patient satisfaction, and you know, actually changing their physical buildings and the way that they deliver their care, you know, to help encourage their patient satisfaction and safety. So a couple of questions I just have here are, like you mentioned, Kay, how do we encourage our patients to share their good experiences? Because so often, you know, all of us really are only inclined to fill out a survey if it's a bad experience. But, you know, we all know that this has such great impact on our financial and quality scores that we really need to be emphasizing on the good experiences. And then also, I think it's just really important to establish realistic perspectives for patients, because I know, you know, with working in my days in labor and delivery, oftentimes women come in, not just the patients, but their families. They come in the door and they expect to have, you know, champagne and steak and crab as a celebratory meal, or, you know, a Tempur-Pedic mattress after they deliver. So I think we really just have to establish those realistic expectations of, you know, what they need to expect during their hospital stay, and that we certainly do everything we can to get them out the door as soon as possible. You know, another thing that I think is really important is we all have a choice in our healthcare and where we go to seek our healthcare, especially for a hospital stay. So what are we doing to attract patients to, you know, choose our hospital? And then, you know, following up on how we encourage patients to fill out the survey, even if it is a bad experience. You know, we want to make efforts real time to change those experiences, so that hopefully when they receive the survey, they'll actually, you know, give a good report.
Yeah, That reminds me of a case one time when a patient was yelling at us saying their expectations of having their trash emptied every 30 minutes was not being met. So sometimes setting those realistic boundaries is really good. I'm going to go forward with just the HAC program just really quickly. What is it? It was one of the first ones that was started in 2008, and the goal was to identify, preventable issues based on evidence-based guidelines. And if you haven't looked at the IPPS that Cindy and I both have mentioned for 2017, they've made several changes in the HAC program, including how it's scored. So be sure to review those and take that information and apply it to whatever program you're currently doing. I'm going to quickly talk about never events. They've been around for a long time, and now Canada and the U.S. both have requirements for the never events. I love this cartoon, is it your left arm? Right, it's my left arm. And I had a friend that her son just went in for hernia surgery 2 months ago. He was asked 5 different times which side. They marked it, and guess what? The surgeon still did the wrong side. So workflow can only take you so far. You got to hold people accountable and come up with ways to prevent it. Real quickly then, the HIA, I just want to give you some statistics real quick. Among acute care hospitals, they have found that between 2008 and 2014, a 50% decrease based on this tracking. There was no change overall in CAHI between 2009 and 14. However, they saw great progress in non-ICU settings. And the SSI, they reduced by 19%. Abdominal hysterectomy, SSI, decreased 17%, 2% decrease for colon, 8% for C. diff, and 13% for MARSA. So what does that say? They're getting results. These great results have told us that a program that you're held accountable for can make a difference in how and the care your patient receives. So Cindy, I'll let you kind of give a little overview on both of those.
Yeah, just really quickly, because I know we're kind of getting close to the top of the hour. I've pointed out just some high-level bullet points here. A lot of these are process improvement focuses that many hospitals already have in place. So, the main focus is that we're just delivering high-quality, patient-centered care, that staff-patient ratios are appropriate, and that, specifically we want to make sure that our new folks to the hospital or new graduates are receiving the appropriate training and communication that they need in order to deliver that high quality care.
Okay, I'm just going to quickly go over the outpatient, and the only reason I put this in is because I think that we're going to see this program grow because more and more services are being rendered on an outpatient basis. It started in 2006, and if you don't participate, you will receive a 2% point reduction. So I keep talking about the point reductions. Each one of these programs has an incentive in some cases and a penalty. So Cindy, what are the top OQR measures that you think that people should be really thinking about?
I really continue to think that stroke is going to be a big focus. Safe surgery checklist and timeout obviously there's a high need there. Also, mammography and colonoscopy are really becoming high focuses. And then the healthcare personnel influenza vaccine, just with our increased prevalence of influenza in certain years, it's really important to make sure that our frontline folks are being covered for that.
Okay, thanks. I'm just going to throw in just a few slides at the end, and the only reason I'm doing this is because I want to draw your attention to what's happening on the physician side. So they've had the PQRS program, which was our equivalent of IQR, but it's changing. MACRA, if you haven't heard about MACRA, we had a webcast a few months ago. We'll send you those slides. We'll send you the playback. You need to be aware of this because it is CMS just announced a few weeks ago that they're looking at doing the same thing on the hospital side. So I just wanted to give you a couple of slides about what changed. One of the programs under MACRA is MIPS. It's a merit-based. It allows more freedom for doctors to choose, but let's look at the downside in a way. The quality category, this is what's replacing PQRS. So this is where they're going now. They are going to, it's still in the comment period. We'll see the final. There's been a lot of bad press about this, but I can guarantee you that they're going to move forward with this, and we're going to see the same thing come out next year with hospitals. You know, they said they were getting rid of meaningful use. Well, this is what they really are doing. They're just changing the name of it. They're changing some of it. It's not no more an all or nothing like it has been, but it's still going to be there. And I look, my friend told me 3 years ago that works at CMS under the Meaningful Use program. She said, Kay, even after meaningful use, we're going to continue to require reporting. So you can see right here, this is what's probably going to happen on the hospital side too.
So the real key here is don't delay or you're going to pay. So as Kay and I have been talking about, these financial penalties are really huge. And what can you do to be ready? So I find this graphic really interesting because I saw that and I really feel like it's just the evolution of where nursing has come the last 100 years. Our patient focus has always been the priority, but now there is so much more emphasis on what we're doing with our documentation, electronic reporting, quality reporting, all of this. So truly what we do with our frontline staff is a direct impact on our quality. So again, like I mentioned before, making sure that our staff are trained appropriately and really focusing on an emphasis on continuous quality improvement, establishing those departmental teams and getting everyone together where there's not the separate silos so that everyone has the same focus and same goal. And it never hurts to provide some incentives. I know that, you know, a chocolate basket or a cookie basket, all of those things are really beneficial to kind of just provide the encouragement that everyone needs to keep this going. So just really quickly putting it all together, just some questions. How do you approach your QI program? How is that performance measured? What kind of things are being done to improve your outcomes and focus on the continuous quality improvement? Again, using those incentives are really beneficial. And then, you know, something that we never like to talk about, but how are those poor performers being held accountable? If you have a physician who is just not getting on board with electronic charting, you know, making sure that they're evaluating and making improvements within their quality performance, what is being done to hold those folks accountable? Again, just aligning all of the teams, making sure that the C-suite is all on board and quality, clinicians in the front line, all of this patient-centered care has a direct impact on your quality of care and your quality reporting. So one thing that Kay and I just really wanted to focus on is, you know, is quality a hospital staff responsibility? Kay, I know you have a lot of input on that one.
Yeah, I was just going to say, when I was a director at the hospital, I had 5 departments, and the thing to remember is CMS is going to continue to change these plans. We have to be prepared to make changes too. And the other thing is, when they come out with a new program and they have the comment period, please make your comments. You know, I noticed that recently one of the comment periods had very little comments made till like the last day. So it's our time to give the voice and say what we think should change or not change with the program. And hospital-wide staff, the reason we said that is everybody in the hospital has a part to play in the quality program moving forward. We just wanted to share this with you. This is one of our customers. They said we could share it. They create a document like this on every one of their quality programs. They come up with what their process is, what their goal is, what they want to shoot for. So we wanted to share this with you. If you wanted to have a way to write down and have documented what you're going to do for your quality game. And one last topic, I've talked about the IPPS. The comment period ended in June. The final rule will be published August the 22nd in the Federal Register, but we already know what's included, and Cindy brought up what's going to be happening in the CQM world. We thought that they were going to make you do 15 eCQMs. They're going to jump from 4 to 15, so they have backed down on that, and we feel that's very good. Cindy, do you want to make any comment about the IPPS final rule before we end?
I think we have just a couple minutes just to take some additional questions, and then want to make sure that we give everybody their time back.
Great. One question. I thought I heard readmit rates are going down. Do you think CMS will keep that program long term?
I'll be happy to address that. I've been reading that too. And there's been a lot of negative comments about the readmission program and the 30-day and all of these programs. I feel like they may alter it, but I think that they'll keep that program because of the reimbursement, the financial impact that the hospital has. Because what I found was hospitals were finding ways to game the system. And I think CMS, unless it goes drastically out of no readmits hardly at all, I think for the next 3 or 4 years, we'll see that readmit program stay around.
Okay, and then one comment was, I heard the newborn here screen recently changed and may affect readiness for reporting under CQM.
Cindy?
Yes, that is correct. The EHDI 1A, that's the abbreviation for the newborn hearing screening. That is going to be one of the main eCQMs used for reporting in the future. So honestly, it's a CQM that is fairly easy to capture and one that is mandated. So it may require some double documentation, across different EMRs, but it is something that's easy to capture. So I do encourage my customers to, start looking at implementing that workflow.
Okay, if there's any more, Chris, we can answer them and send out with a follow-up. I'm just going to turn it back over to you.
Great. We do want to thank everyone for attending our webinar today. And as I mentioned in the opening, you'll have the opportunity to fill out a short survey. We really appreciate you taking time to do this. And this survey will appear when you leave the webinar. For your time, your name will be entered into a drawing to win a $100 Amazon.com gift card. All those drawings are held at the end of the month. Follow us on social media and our blogs for healthcare IT updates and to interact with your peers. And if you'd like more information, please contact your IATRIC Systems account executive, or you can send an email to info@iatric.com. I'd like to thank Kay and Cindy. I'd also like to once again thank everyone who took the time to join us. We hope you have a great day, and this concludes our webinar.